All right, hello. Welcome to another episode of the Down Fracture Podcast, a podcast for talking jaws. Basic housekeeping as always, downfracturepodcast at gmail.com. If you want to send us cases, topics of interest, other things, feel free to do so there. Otherwise, we'll get going this morning, afternoon. It's afternoon here. Where is it? How's it where you are? Morning?
It's morning still.
Yeah. How's it going, Sam? I guess maybe I should start with that.
It's good, Mike. Yeah, it's good to be here again. It's just us today, right?
Just us today, talking about condylar fractures and whatnot. So, are you seeing much of these?
Well, there's a time in my life I took care of trauma is kind of my primary focus right out of fellowship. I took trauma for about 5 years here in Seattle. Now I'm out of the trauma call. So I see more secondary reconstructions like you do, I think.
Yeah, I'm similar. I did the same thing with you for a couple of years, few years in Seattle. And then, yeah, everything I see here now is mostly revision or occasionally, maybe once or twice, I've had someone just find me on their own of like, hey, I was out of town and this happened. And I came back here and was looking for help and I found you kind of thing,
Yeah,
or
so
someone else directed me your way.
I think it just has to do with the different practice. I mean, when you're covering emergency room, you tend to see a different volume of trauma than you do when you're in kind of private practice on your own. But I would say of the trauma that I see, it's generally TMJ related stuff.
Yeah, agreed.
But yeah,
Agreed.
today's discussion is on condylar fracture management. Is that what I'm seeing?
That's what you're seeing, and I'm trying to figure out the best way to show this. What are you seeing now? Do you see us and my screen shared, or what are you
Yeah,
seeing?
I just see your desktop, I think.
Okay, good.
It's got the general slide there.
Maybe that's what everyone else is seeing then too, because they don't need to see us. Well, yeah, so I think we have similar perspectives. I mean, I guess my first question to you would be, do you think that skews our perception here?
Yeah, I mean, I think because you and I are fairly aligned on this topic. I mean, it came up last week when we were talking to Hope in terms of what she sees on physical therapy. And when I was doing more trauma, this seemed like an easy call in terms of open reduction versus closed reduction of condyle fractures. But I think it was a good topic to bring up just because, like Hope, we still see people who get treated with closed reduction of condyle fractures, and
All the time.
particularly dislocated condyle fractures. I mean, I definitely see those patients, which is it's to me a little remarkable that still goes on. What do you think?
Yeah, I mean, you and I, of course, debated this subject, and debate is probably not the right word because I think, like you're saying, we're pretty aligned. But I do think there's other variables to discuss in this topic beyond just what is the right way to manage this. And I would ask the question to you, and I'll tell you my experience is, were you guys opening these routinely in residency in Portland?
Because um, I think when I was in residency, it was still up in the air what was the right approach. And condyle fractures in a busy trauma service are pretty easy to be set aside as closed reduction. You know what I mean? Like if
Absolutely.
you have 10 fractures on a Saturday, changing a closed reduction of a condyle fracture to an open reduction changes the time dramatically. And that sounds bad, but it did influence kind of
No
how we
doubt.
manage things, and it was very dependent on what faculty was staffing in that part.
No, you're going right where I want you to go here because I think the easy thing to do is debate and talk of the merits about open versus closed treatment. And of course, I want to make sure we do that. But I think some of the other things that you're mentioning come into play because I would throw another one at you. Cost is huge difference here, right? Closed treatment versus open treatment.
Yeah, I mean, I guess cost on the individual surgery, is that what you mean? Like
Yeah, I
comparing
mean,
closed reduction surgery versus an open reduction surgery?
yeah, I mean, you're talking at most some arch wire, arch bars and wires versus hybrid MMF versus IMF screws versus embrasure wires, comparing the costs of any and all of those to utilizing those things maybe anyways, and then opening a fracture and putting fixation on and the anesthesia time,
Sure. Yeah, no,
et
I
cetera.
agree on that. I think before down we get down that road, I think we're both on board that closed reduction is a good management strategy and an open reduction is a good management strategy for condyle fractures.
Yep.
It's obviously dependent on the clinical situation and whatnot. But on displaced condyle fractures, like fractured dislocations of the condyle, I think is a low-hanging fruit that we can all get on board. That open reduction should be done unless there's some other crazy thing happening, like their pan face injury and they have other more acute issues to tend to, right?
Yeah, I mean, I think you and I can get on board with that. I still think there would be people who would have objections to that. I mean, I think we run into this all the time in practice is people who have a difficult time of letting go of what they were taught, trained, and what they've utilized for years, if not decades or more.
Yeah. So, but I mean, closed treatment is good. Open treatment exists, and there's some clear situations where open treatment should be like your primary consideration, right?
Yeah,
You
I
have one of
mean,
the on your screen, you think that the location of the fracture is one of those considerations.
I do, and I think the when it comes to these things, the maybe what you're referencing is that as far as clear indications, there was what that classic Zide Kent paper that had like absolute and relative indications for open treatment of condylar fractures.
Yeah, I mean, we all got like harassed about that thing when we were
Oh,
residents,
over and
right?
over.
I mean, it's that's an old paper, right?
And then they modified it, and then other people
Yeah.
have, since kind of carried on the work. But yeah, I mean, and yes, I mean, I think some of those, just for the listening audience, would be, like displacement into the middle cranial fossa, foreign body. Um, Trying to think of
Open
some of the,
fracture,
yeah, if it's a
bilateral condylar fracture
loss
with
of vertical
midface.
height and panfacials and other things like that, where they kind of say, hey, there's clear indications and then some relative ones. But I think we've even evolved from that standpoint, right? Like we're no longer just leaning on that research and paper. I think you and I probably at least feel like you should be able to look at this patient situation and make a pretty good informed decision as to what the best treatment option would be for that patient.
Yeah, so can you click a couple of slides? You had a case where um I'll describe what I'm seeing. So we're looking at a right-sided condyle fracture. It's a fracture dislocation. The condyle is anterior and it looks like medial to where the fossa is.
Yep.
And I'm unclear if there's other injuries here, but just looking at the right condyle in this scenario, this would primarily be an open approach, and I would have to have some pretty good reason to not treat it open.
Agreed.
But if I lean back to my time of training, which I started training 20 years ago, that makes me sound super old.
I thought it was longer, to be honest.
Yeah, thanks. There's a philosophy from condyle fracture management that you can just treat any of these closed. So wire their teeth together or band their teeth together for a period of time. And then through vigorous rehabilitation and physical therapy, they can regain normal or near normal function. And I think what came up last week through physical therapy is what I observed over the last 20 years of practice is with that I don't think people can really rehab to the same, right? Like
No,
you have in the situation of a condyle fracture, you have an otherwise normal functioning joint and they have an injury, and then you have this fracture dislocation of the joint. I can't imagine other parts of the body in an otherwise healthy person you would accept that the joint is dislocated and you're just going to rehab them
you wouldn't.
to that anatomy.
You wouldn't.
Because if this is the shoulder or the hip or any any number of joints, the primary focus would be reducing the condyle.
No, absolutely. I think if you want to see proof of that, look at the sports world. And I saw a video of someone recently, old football player, they were notorious for fracture dislocations of their finger, offensive, defensive linemen. And then they'll hold up their hands as they're talking and gesture, and you see a finger that's like 45 degrees one direction or the other, and they can barely move it. And it's because they just kept playing and didn't take the time to get it, treated in season. And I think similar here, maybe not to that magnitude, but I think part of the issue when we discuss this is if you read the literature, and it's been a little while since I really looked at it in much detail, But I think part of the problem is that we look at outcomes as, and it'll even say this in the literature, as acceptable or reasonable,
Yeah, yeah,
instead of looking at what is the optimal, which achieves the ideal, or what is the most superior outcome we can achieve. And if you look at closed reduction, or it's not even closed reduction, that's the other problem. It's closed treatment. We're not actually reducing it. And I think that's the other thing that we misspeak on all the time.
sure.
But it's, yeah, maybe you get to an acceptable place, but by whose standards? Like, I mean, and what does that mean? 30 millimeters of opening and minimal pain and can eat most of what you want. Is that's acceptable? Maybe. I guess. I don't know. But I mean, I think when you compare the optimal result, it's pretty clear that open reduction internal fixation of displaced fractures yields superior outcomes.
Yeah, no, I think the literature is pretty clear on that in terms of mouth opening, regaining, translating movement in the joint, occlusion. Um, and that would make sense, right? You don't have to know too much about any of this stuff. If you look at that three-dimensional X-ray, and it's like, well, what should you do? I mean, ideally, you get those two bones touching each other, right?
Right.
It's just the technical bit of doing that is, I think, what keeps people away from doing it.
No doubt. And before we get there, let's just, we keep speaking matter of factly about the literature, but just so people aren't taking our word for that who maybe are not familiar with this topic. So I do have a couple papers up here. I had a couple others that I couldn't find that I read, and I tried to put a meta-analysis on here, which is what this one here on the left is.
Because that one's from
Um,
2013, 2015, something like that.
I had one that was from 2013, which is this one. This one is from, I think, 2020. Let me see. Well, whatever. It's more recent. But the reason I put the meta-analysis is there is because you can, if you search, and we all know this who read literature regularly, if you go search for an answer, you'll find it. And so I was trying to not search for papers or put papers on here that just scream open reduction is better or closed treatment is better. So I wanted to get the meta-analysis on here to kind of maybe eliminate some bias. And this was only of randomized controlled trials. And they kind of said exactly what you just said is pain, occlusion, function, TMJ function independently, all of those things have better outcomes with open reduction internal fixation compared to closed treatment. So just so people know we're not just making this up and don't have an agenda. And then this paper over here, I saw it and I didn't see it till I was trying to pull stuff up, pictures today, and I found it. And it was kind of interesting in that it looked at it not from a open versus closed type debate, but from a position of the condyle perspective. And they kind of found that condylar position within the fossa or relative to the fossa was what they found to be the predictor of the patient's outcome. And so even if it was closed treatment of a basically a non-displaced fracture, versus reduction of one with open reduction. Basically, what I'm saying is the condylar position relative to the fossa was the predictor of how the patient would do, and not open versus closed treatment, which kind of coincides with what we're saying here.
Yeah, because I mean, I definitely find the literature's hard to narrow down the situation that we're talking about, right? Like this is very much like TMD stuff. Because a non-displaced, condylar neck fracture on its own, as long as the condyle is in good shape, I could see them rehabbing to the same extent if you put a plate or not on there. It's just a matter of time, right? Like how people tolerate the surgery versus having a period of closed reduction. But on fracture dislocations, and you take the extremes out, right? Like the very old and the very young, in the teenager, 20-year-old, 30-year-old, kind of the wheelhouse of trauma patients. Um, I feel like fracture dislocations is pretty clear that open reduction is the right approach.
Definitely. And the other variable I'll throw out there at you is it's not uniform. It's never 100% or 0%, but the trauma population as a whole, I think the more you're relying on them to have an impact in the overall result, the worse your outcomes are going to be. They're not going to be the most compliant patients. They're not going to go to PT every time.
Well, because
You
that's the
might
other
not
thing
see them again.
that's the other thing I think that the what we're referencing in terms of residency, because in training programs, a lot of times they're covering the level on trauma centers, and the patients are different than say the patients that might show up in your office or my office,
Right.
which would be very much, like if we fell and had a fracture dislocation, how would we get it managed? And 100%, I would have a open repair if it could be done. Like if it
Yep.
could be done, I on myself or my family, I think that's the right approach.
Yep. So what so what are the other barriers or variables here? Like why is this? Because again, you and me, it sounds like we're in the same boat as I see a handful of these a year, but I don't take trauma call. So I'm only seeing them when they have not had good results. So someone else has attempted to wire them shut, put them in MMF for a period of time. When that's off and they have a malocclusion, then the typical story I hear is I had rubber bands for a few weeks, nothing was getting better, I found you. Or they cut them off and now I can't move my joint very much because I have this physical obstruction. So why does that persist in your view? Like, why are we still wiring people shut?
Well, because I think it has to do with how few people actually do TMJ surgery. Because in a fracture dislocation, I mean, you're showing something a little bit different, but I tend to have two approaches, preauricular and retromandibular approach. I usually approach it in a similar way to TJR. Obviously, it depends on the scenario, but neither of those approaches stress me out in particular, right? Because it's just like a normal thing in practice.
Right.
And I feel like we're a little bit unusual in terms of that practice. And so if it's been, 1, 2, 5, 10 years from residency and you haven't opened a joint, then it's like, well, let's just treat you closed and then, we can refer you out or something of that nature, right?
Is that the
Uh,
right thing to do?
I mean, I don't think there's anything wrong with that. I think as long as you send them down a path of finding someone for open treatment, I think that's a reasonable strategy, right? Because
So you're
it's
saying like temporarily lock them down and while you're trying to get them to someone, is that what you're saying? Or you're
Yeah,
saying
yeah. Yeah, I mean,
treat
because
them closed?
otherwise, because the reality is it's a big country and there's not that many people in anyone's state that does this sort of thing. And while we're living in the world of not many oral surgeons are doing TMJ surgery, you kind of have to find people to help you out. And it's going to be academic centers, it's going to be, practices such as yours and mine, those sort of things to help. And in the meantime, if you're trying to find those, I think temporarily putting them in IMF, I think there's very like practical reasons why I think close reduction persists. And I could be wrong on this. I'm just trying to give people the benefit of the doubt and understanding that how practice is practical frequently. You know what I mean?
Yeah, the other variable I would say in this is, and I don't know the answer to this, but it seems to be, so if we look at it this way of basically three groups or three specialties that treat facial trauma, ENT, plastic surgery, and us, we probably have the most comfort in accessing these areas for open treatment comparatively, right? Like I would say ENT, plastics, other thing, they may be more comfortable in the neck and stuff, and they may, some of them, they go to the parotid all the time. But I don't see a lot of those professions in my history or experience opening these. And so there's two-thirds of the facial trauma in theory that maybe this isn't even an option. And
Yeah, you're
then
right. I mean, there's different specialties covering it for sure. At Oregon, we had a plastic surgeon who liked doing transoral approach for condyle fractures.
mhm,
And he published a good bit on it. But again, transoral approach for fracture dislocation
that's
is
tough.
is hard. And I mean, that's a hard surgery anyway, just from putting a plate on a non-displaced subcondylar fracture. But a displaced one, if anyone's considering doing that, I would caution you that that's going to be difficult as someone who's tried such a thing.
Yeah, I'm not a fan.
Just come from outside. It'll be easier. So,
Yeah,
but yeah, I mean, I think different specialties, and then just there's a lot of injuries. So
absolutely. And yeah, I mean, I think there's reasons why that persists as well. And I don't know how to solve that problem. Maybe there isn't a solution. And then, I mean, I would also say, I talked about your experience earlier. You talked a little bit about it. I asked you, but I did not treat many of these open in residency at all. If I did maybe a handful, I would say it's probably not anymore. I'm right in that area of opening these a handful of times in residency.
And if I remember right, your residency was such that you didn't learn a ton of TMJ surgery.
I did not get a lot, no.
Yeah, so
We were frequently accessing things for other reasons. So the access part to me wasn't too scary right out of residency, but you're right. You lose those skills if you don't use them. We didn't do it. It's definitely not an intraoral incision, which, we're all comfortable with, right? But um, yeah, so I got minimal exposure to this and not a ton of TMJ surgery. And so I think that's kind of the point I'm getting at is I think this has a way of self-perpetuation of, if I had gone out into academics and I wasn't really experienced opening these things up, then that's probably how I would have treated most of them. And then, well, there's the one, two, three, four, five residents a year that I'm training that are now getting that as their experience. And then they go out in the world. And I think it has a way of continuing in that regard.
yeah, I mean, I think it'll get better, or at least I hope it'll get better. But I think what you're describing is very similar to surgical and non-surgical TMD treatment, right? Like it's
Absolutely.
just very much like people need help otherwise, and so you kind of get the help you can. But I think fracture dislocations, more so than other fractures of the condyle, are so clear winners for open reduction. They're just they're clearly helpful, and for whatever reason, that message doesn't get sent out to the I don't know, to my neck of the woods, and it sounds like your neck of the woods. So I think it's good to discuss it because it's just a harder surgery. Like what you have up now is a revision surgery, is a
Yeah.
fracture.
Yeah.
Yeah. So because I mean, taking a step back again, if you have an injury of a condyle and the condyle can be reduced, fixing that in the first couple weeks just makes the secondary reconstruction that much easier. The secondary reconstruction is performing a condylectomy cut. You're showing an image of the condyle outside of the body, and you're using it as a free graft as you would for a rib graft or anything of that nature,
Yeah.
uh, to put it back into the site. Whereas that may not be needed in the primary repair. Treating someone as a joint replacement, as a fracture dislocation that can't be repaired, I think there's good reason to do that, actually. I think particularly older people, um, which is a talk for a different day, but I feel like that's probably a little bit more controversial than what we're arguing in terms of fracture dislocations.
Yeah, I would say since we do have this picture of me taking it out, what my goal to usually is, or my hierarchy or algorithm is just what you're saying. If I can just get this back into position with disk and everything attached and functional, that of course is my preference. But when I've seen them late, sometimes there is just I feel like there's even scarring of the lateral pterygoid. There's a lot of resistance to even once you've made the condylar osteotomy. I find that it's not simple to
No,
just put that thing back. You almost have to like put a screw or a wire or K wire or something in it to have something to hold to try to hold it into position while you fixate it. And then I don't know that that degree of stretch is great. So like that's what I try to do. And then if I'm just struggling, then I typically strip it and take it out like this. And I don't know that that's the right answer either.
because I mean these situations, I think it's a fine technique in terms of it. I mean, it's a free graft. Surprisingly, those things tend to survive in that scenario. But
Yeah.
what you're describing in terms of like a later reconstruction, I mean, they're scarring in the joint, right? Like they're trying to reform their new joint. And this isn't, like a 4-year-old injury, like a 4-year-old kid injury. This is, like a 25, 35, 45-year-old person. And there it just stands to reason that they would have scarring in their joint space or their new joint space that's going to get in the way of the secondary repair.
Yep.
Um, and so I think we were talking about before we came on about, finding discs. I had learned in fellowship that maintaining the disc in these situations was an important thing. And it certainly seems to still be true as time has gone on. And a late repair, the disc is scarred, maybe more injured than otherwise. And so kind of doing a secondary repair, I think, do you have a time limit that you would just say, hey, look, no, I'm not going to even try this. Let's just do a
No,
joint replacement.
no, not yet. That's kind of what I was getting at is like I tend to do this. And, the first few times I did this, I think actually you and I spoke and I was nervous. Like you're saying, I was like, man, I stripped the disc and, and the muscle. Like, and I was worried. I was like, I don't know that this is going to survive because similar to you, disc is important, muscle attachment for vascularity is important. But you're right, and what you said to me then and what I knew, but it was nice to hear is like, hey, this is just like doing a free graft. Like this is what you would do if you took a rib or whatever else you were doing to reconstruct. So I've had to do this a few times. I'd say at least somewhere between 3 and 5 times in the past couple of years. I've basically had to take the condyle, make my osteotomy and almost take it out, put it back in, and fixate it. And short term, they've done great. I have worries long term, and that would lead me to why I wouldn't primarily do joint replacement. I would try to give this a chance and see if it even buys them some time. And if they do okay, we've avoided that. Um, but the other question I would have to you would be in this scenario, I've often thought, should I be putting fat up there? Like, should that be on my consent form? Should I be putting fat up there? Because the other part of the disc and the muscle that you hear and read is helps prevent heterotopic bone and ankylosis and fusion. And like, if I'm just putting this in here, should I be taking fat from the abdomen and putting it up there too? Do you have thoughts on that?
Yeah, I don't know. I mean, I haven't traditionally used fat in these situations. I mean,
Either.
I think on the extremes, I think this decision's easy. Like if you're catching someone in the first year, then, performing an osteotomy and repositioning the condyles is
Oh, is that what you
doable.
meant? Sorry, maybe I misunderstood your question. I
Well,
thought you
no,
meant
no,
kind
but
of like in
I
the
think
acute, subacute
we're talking about the
setting.
same thing. I think on the other extreme, if they're like 10 years out, right? Like if
Oh
they
no,
have
yeah, I definitely wouldn't do this and that. I'd go to
like
joint
you
replacement.
can't do that. So it's
Yeah.
like, well, what about the in-betweens, right? And I don't really know. I think doing something like you're showing here and a person who's like, 70, I don't feel great about. I think in the right clinical situation in a young person, I don't feel great about this. I think for healthy people, then, this approach seems very reasonable. Um, because you would be doing this in someone who otherwise is having trouble, right? So you would
Yeah,
have
you're not
already
doing it
tried the closed reduction, they didn't do well.
exactly. You're not doing this as a first line treatment. They've already failed the alternative. And short of going to joint replacement, I don't know that you have other options here. I mean, I guess if the problem was purely occlusal, then you could entertain osteotomies, sagittal osteotomy or any other kind of osteotomy to fix the occlusion. But most of the time, they have accompanying pain or limited function, and that alone is not going to solve this problem.
But I just, and again, it could be biased by the people I end up seeing. But if I can treat it primarily like as the original fracture, everything is so much better. Like it's just easier to reduce. Seems like it's easier to heal. I have to believe longevity, that sort of thing is better. And so I don't know. I think the limitation in terms of practice has to just do with people's comfort in TMJ stuff, which hopefully we're improving, right? Like by us talking about this, I hope to kind of get a little bit more um, kind of focus and interest in people to kind of seek that sort of treatment out more often.
Yeah,
And
I mean, to me, this is purely an access issue, right? Because I think even, a lot of academicians who we interact with at times who still treat a lot of these closed, I think it's an access issue. I think if those people felt confident accessing these, then I think there's a huge shift there. But
yeah, I mean, residents, if there's any residents listening, I mean, I think you were like this too as a resident, but I was very like, I wanted to try every technique out, right? Like
yeah,
I wanted, the historical techniques, I wanted different ways to approach things just so you can learn it. And so convincing faculty to open condyles, I think, is doable. I mean, independent of the program, you just gotta, do the resident magic to
yeah, I
advocate
mean,
for the patient.
that was kind of our struggle is like, can we can we try to do some of these? Can we? And then it's hard. some faculty you just know it's going to be a hard no, and then others who maybe are a little more open-minded and or comfortable with bigger surgery and doing these things, yeah, you can do it. But absolutely, I think this is a tool in the toolkit that you want, and you can get it other ways. You may not, path and other reasons, TMJ surgery, you get comfortable accessing things. And if you can access it, that's the key, because otherwise it's what, just putting bone back in place and putting plates and screws on. That's what we do all day, every day. But yeah, I think there is that fear of facial nerve injury and scarring, just like with TMJ surgery, that if you are comfortable with it, I think is overblown. Those aren't real major issues in my practice. Not that they don't ever happen, but
Yeah, no,
I
I think that's an unusual problem. It really is. I mean, some temporary weakness and marge can happen, but
yeah.
TMJ access, I mean, temporary weakness is actually pretty unusual. So I think your next slide has reduction of the fracture. I think
Put some Try to get some variety on here.
yeah, no. I mean, I just kept looking at the little condyle sitting there. But yeah, I mean, I think in general, when it comes to this, I think overcoming those limiting factors in practice, having people to refer to, just reaching out to different practitioners who have interests in this sort of thing, and just talking with the other oral surgeons that plastic surgeons, ENTs, those guys are all, they're we're all very similar in that we're just looking for people to help us out with different issues, and connecting with ENTs is great because then they can help you out with the oddball ENT stuff that you need help with. So I think
Absolutely.
networking is always good when it comes to this stuff. So
Yeah, I mean, I think you hit an issue on the head there, whether you meant to or not, is I think that's the other part of it is I think sometimes ego even comes into play, right? Like, oh, I can treat this, I'll treat it close because that's my toolkit. And maybe ethically or responsibly, the better thing to do is try to find someone to take it on, and have that connection or refer them. And I don't know that that happens enough as it should, as much as
yeah,
it.
I mean, I don't know. I'm like thinking optimistically on this stuff. I think people try it out. It's just, everyone's busy and everything else. So,
I'm not
and
saying
there's
there's
like
not good
insurance
reasons.
limitations, there's like
Absolutely.
regional, there's patient, like I can come up with a lot of scenarios. So, but in general, I think open reduction of fracture dislocations of condyles, pretty clear. Open is the right approach.
Okay. Do you have any tricks, tidbits, anything that you would pass on to residents or other people who are looking to do more of this?
I think the different plates that you have a straight four hole plate. Those are pretty solid. I think there's those Y plates that are pretty good too, though, because they give a little bit better three-dimensional stability. That shows, I don't even know what that would be
I think they
called.
just call it either a rhomboid or a deltoid plate. I think I've seen both used, and
Yeah,
maybe
the
there's a
the
little bit
ones
of a
with like the
difference. I
two
don't know.
arms to them, so they can wrap more towards the cornoid process. I think in high condyle fractures, the condylar head is softer than you would think.
Uh-huh.
That's tricky. I think lagging condyles, when you read about that from international stuff like European journals of lagging condylar heads, that still stresses me out, by the way.
Me too. I
It's
haven't
like,
done it. I don't know that I will.
but I mean, reading that literature is it's provocative that you should try it out. It's just the very real drilling stresses you out of that because you have to come from inferiorly, and then you need to stop on the medial pole of the condylar head, right? Or the condylar neck. And
Yep.
there's some rather important anatomic stuff in that area. Um, but yeah, I think the technique of the two approaches tends to be helpful.
Yeah,
And
would you for access, you kind of touched on it earlier. What do you do? You do two incisions almost standardly, or do you?
yeah, I mean, I generally like that. I mean, I know of just direct down to the condyle, like the transfacial approach, I think is what it's called. The single approach to condylar neck fracture. But with fracture dislocations, like I really want the condyle to be in a reasonable position with the disc, and I just find it's hard to reduce those sometimes. And when I've tried to just do a single approach, I like talking to people about, hey, it's going to be, 2 incisions, and that gives me flexibility to kind of manage it in the right way, right?
Yeah.
Um, and I don't know, I generally start with the preauricular approach and then just go from there if it can't be sorted out.
Yeah, I've kind of modified my approach to that over time. When I first started doing them more, I was doing mostly just a retromandibular incision, and I think that had a lot to do with the first ones that I were seeing. A lot of them were more inferiorly located. They weren't high condylar neck fractures. They were more subcondylar lower fractures, maybe like that what I was originally showing, maybe this or lower. And trying to reduce those from below can be a huge pain in the ass. And then I kind of went to doing both incisions. Like you said, I always consent for both every
Yeah.
time, every single time. But where I start now, I think it's changed. I kind of do what you're doing now. I start with the preauricular incision instead of the retromandibular. And I think the last two that I've done just with a preauricular
Yeah, because I mean,
incision.
it's like the single incision approach to TGR. Have you heard about that one? It's
You've
kind of
told me
silly.
about it.
Not that I think
I
that's reasonable, but just because the facial nerve injury rate's high in that approach. But I mean, in the non-displaced fracture or the minimally displaced fracture, doing transfacial or retromandibular approach, I think is fine. I like transoral approach for that injury. But if it's dislocated, I kind of want the joint anatomy to be prioritized. And so approaching the joint seems to, without getting too lost in the weeds, seems
because
to
you're
be
kind
the
of
right
guessing,
approach.
like you're saying, like that was my problem is it's physically hard to reduce it from just a retromandibular incision at times. And then you're kind of eyeballing it, right? Like you think you're in the fossa, but you're not, often real certain if you're just using that, if you're just coming from below.
Yeah.
At least that's been my experience.
Yeah. So I think the two approaches are just the primary preauricular approach is nice. And then sequencing of reduction, rubber bands. I would say that's my other tidbit I would tell myself. I remember I was trying to teach myself transoral approach for condyle fractures because I thought I needed some reps of that coming out of residency. Um, and using rubber bands makes that way easier. Like
What
rubber
do you mean?
bands on your IMF.
So you're saying when you go intraorally, you put like once you've accessed it, you put them in elastics and then try to reduce and
Rather
then
than using embrasure wires or 24 gauge wires through your TADs or your arch bars, or whatever you're using, right? Putting rubber bands on so you can allow for movement of the ramus. And so,
while you're trying to reduce.
yeah,
Oh,
totally.
okay.
And then you
Uh,
can tighten it up afterwards. It's just, because you can lose the condyle frequently medially, and it's nice to have a little wiggle in the ramus. So if I was going to tell myself some advice when it came to fixing these things, I would remind myself of that. So
okay.
rubber band IMF is nice. And then you can always put more
Tentative.
bands on, right? Like once you get it reduced and you feel like it's stable and you got the plate on the condylar component, then you can just tighten them up, right?
Yeah. Yeah, I'm trying to remember if I don't think I've done rubber bands. I think I've kind of done light, like I think I've kind of gotten it fairly reduced, put them in light IMF, try to reduce
What's
it,
light
tighten it up.
IMF? Like loose wires?
Yeah. Yeah. Just
Oh, okay.
not, or, like you and I know both do, if you're using IMF screws, tighten the wire most of the way down, but the last little bit of tightening comes from retightening the screw so that you
Sure.
don't break the wire. So even leaving the wire a little light and then not tightening the screw, I think I did once. I don't know that I remember that working really well. I would just throw that out there that I think I have tried that, and I don't know that I can say it was better than not doing it.
Yeah,
But
I would try using some bands. I mean, I know we're talking about displaced condyles, but I think in that situation, but also anytime you're doing open repair of a condyle fracture, rubber bands are pretty dang nice because you can have it hold it. You can hold the mandible somewhat tight, but it still allows for some movement at the ramus. So
Hmm.
maybe that'll be helpful. So I'm glad we talked about that.
Yeah. All right.
Well, sweet.
Thanks. Hopefully that was helpful for everyone. So, again, another episode of Down Fracture Podcast, a podcast for talking jaws. Downfracturepodcast at gmail.com for ideas, suggestions, complaints, fan mail,
Yeah.
all that
All right,
fun
man. Well,
stuff.
it was good
All right.
talking with you.
See ya. See you next week.
See you next week.